Hi, Chris Cox, thoracic radiologist from Creighton University. And for this session, we'll be doing Basics of Thoracic Cancer on CT. When you're thinking about thoracic malignancies, there's three primary groups to think about. Bronchogenic carcinomas, to include both non-small cell and small cell lung cancers, lymphoma, and metastatic disease to the chest. There are other malignancies that can be primary in the chest, and there are some special considerations such as mesothelioma for the pleura. But those three primary groups are the ones that you'll generally encounter on thoracic imaging. And so those can manifest in different ways, and those manifestations are what we're going to talk about today, to include pulmonary nodules and masses, lobar atelectasis, lymphadenopathy, mediastinal masses, and pleural disease or unilateral whiteout. In this example, I'm showing you scattered pulmonary nodules in the bilateral lungs. Nodules are less than 3 centimeters by definition, and usually for metastatic disease in the lungs, it's a hematogenous spread, so it's going to distribute itself randomly throughout the lungs. You can have other types of spread of malignancy within the lungs, such as lymphatic spread, that can have a different distribution. But in general, the nodules that you'll see in metastatic disease are hematogenous. There is a differential to pulmonary nodules, so you will be considering other things such as infection, but malignancy should be on your differential for scattered pulmonary nodules. For a pulmonary mass, that is a lesion which is larger than 3 centimeters. And as size increases for lesions in the lungs, you have an associated increase of the likelihood that it's a malignancy. Certainly, again, there is a differential to pulmonary masses, such as infection, but as the lesion increases in size, your concern for malignancy should as well. When you have a malignancy that obstructs an airway, it can collapse a portion of the lung. If it is in a lobar bronchus, it will cause lobar collapse. As in this example, which can be very difficult to appreciate on initial review of the chest and can be very difficult on radiographs to see. And actually what we have here is the right upper lobe has entirely collapsed, secondary to a right upper lobe bronchogenic carcinoma. Bronchogenic carcinomas are going to be the most likely cause of a malignancy obstructing a lobar bronchus like this. But it could also be a bronchus intermedius lesion that will take out both the right, middle, and lower lobes, or it could be a mainstem lesion, which could take out a whole lung. A special consideration associated with a lobar collapse is what we call the S sign of Golden, and this is a mediastinal mass, typically, again, a bronchogenic carcinoma, which creates a convexity at the level of the hilum, but along the minor fissure, you get a concavity from the collapsing upper lobe, and this creates an S sort of shape that is an indicator that you have a central mass with a peripheral obstruction, which is consistent with malignancy until proven otherwise. Another manifestation of malignancy in the chest is lymphadenopathy, and there's certain lymph node groups which are most commonly involved when you have a malignancy in the chest. And those are particularly the mediastinal lymph nodes along the airways, so in the paratracheal distribution. Here we're seeing subcarinal and left hilar lymphadenopathy. Depending on the type of malignancy, it can also be along the periesophageal distribution. And then you're also going to want to be looking for lymph nodes in the axilla as well as in the neck base and subcarinal distribution. There are other lymph node groups, but those are going to be the most commonly affected by malignancy in the chest. And again, lymphadenopathy is a non-specific finding, but as they increase in size and also as they develop some atypical features, your concern for malignancy will increase. Mediastinal mass is a special consideration in malignancy because it's going to have a different differential than malignancies involving the lungs. For an anterior mediastinal mass, like we see here, we think of the 4 T's, right? Thymoma, teratoma, thyroid lesions, and terrible lymphoma. This happens to be an example of lymphoma and a nodular sclerosing non-Hodgkin's lymphoma. And they happen to have bilateral pleural effusions. There are characteristics in some of these, such as teratoma containing fat and calcification that could suggest that it's a teratoma, but often you'll encounter these malignancies that are just soft tissue density, and distribution can help with that, other sites that are affected. And often for an anterior mediastinal lesion, you'll have to go on to MR to further characterize it, especially if it's a smaller lesion with just soft tissue density on CT. There are other malignancies to consider if they are in a different distribution of the mediastinum, such as the middle or posterior. For instance, if you had a posterior malignancy, you may be thinking about lymphoma versus a neurogenic tumor. And then for the final consideration here is a process which takes up an entire hemithorax. In this case, on chest radiograph, we see a unilateral whiteout, and with that whiteout, it is pushing the mediastinum away from the increased density. And that tells us that there's a space-occupying lesion there, whether it's a giant mass or a giant pleural process. In a different patient on the contralateral side, they have a pleural malignancy, which is essentially doing the same thing, but on CT, pushing the mediastinum off to the side as it takes up a large portion of the chest with this mixed fluid and soft tissue involvement of the pleura. If you had a unilateral whiteout that shifted towards the opacity, then that would be an indicator that you have volume loss, and it would be more suggestive of a central obstruction, like a bronchogenic carcinoma obstructing a mainstem bronchus and collapsing the whole lung along with it. That's our whirlwind tour of cancer in the chest, and great job.